Factors Affecting Oxygenation Part 2. This is Martha Olson. As we look at the 4 factors that affect oxygenation, we can see that knowing medical terminology is going to be important. Hyperventilation, breathing too fast. Hypoventilation is not breathing enough or not fast enough. Hypo is below. Hypoxia and hypoxemia look very close, but as we'll find out, they actually are 2 different terms or can mean 2 different things, although they are interused quite often. Hyperventilation is increased respiratory rate. This is if I would run around the block and I came back, I would be hyperventilating because I'm out of shape. Other things that can cause that are infections, and that's because the body is trying to compensate. You see this with the mental health and in ER when somebody's having an anxiety attack, or with a lot of pain. When you have a woman in labor and they're not doing very well with handling the labor pains, oftentimes they will hyperventilate and start becoming dizzy, and they get kind of tingly because of the effects of hyperventilation. And that would be under the acid-base imbalance that we see that. As we look at hyperventilation, again, their heart rate usually goes along with that. We call that tachycardia. They might have chest pain as a result of hyperventilation. They become lightheaded because they are blowing off too much of the carbon dioxide. They aren't retaining enough of the oxygen in their hyperventilation state. And sometimes they can even become disoriented as a result of that. Hypoventilation is more serious. When you get to the test question that asks if you were going to go see a patient hyperventilating or hypoventilating, the patient that's hyperventilating will survive, will be okay, but hypoventilation is more serious because the body's oxygen needs are not being met. Collapse of the alveoli from atelectasis. There are a lot of factors that can cause atelectasis, one being damage to those alveoli from being ventilated too aggressively on either a ventilator or when we're doing rescue breathing for them. I broke my ribs a couple of years ago, and I can tell you every time I went to take a breath it hurt. And so your patient that has either a rib fracture or an abdominal wound where it hurts to take a good deep breath will breathe very shallow. The other thing I would put a star and add on here is some of your medications, including the narcotics or the pain medications. They can take away your response to want to take breaths, and a patient with a PCA, a patient-controlled analgesia, where they administer their own narcotics or pain post-surgically, have to be assessed very carefully that they are not going into a hypoventilation. Now that can be anything less than 10 breaths per minute because 12 breaths per minute is normal. So if I walk in the room and somebody is only breathing at 8 times per minute, I am not going to simply leave that patient thinking, oh, they're breathing. They're not breathing enough to maintain where they're at. So we have to look at what would be the treatment for that. If they were breathing 8 times a minute, I'm probably going to go and take away their PCA pump. I'm going to set them upright in bed and tell them to take some good deep breaths, blow that anesthetic out, get rid of that, and I might supply oxygen, or if they have oxygen on, check a O2 sat, turn the oxygen up, and if that doesn't work, then there's a medication that we can give to reverse the effects of that narcotic, and it's called Narcan. And as a nurse, I can give that with a standing order. So hypoventilation, hopefully you got the idea, it's much more serious. What we see in that patient then is they become lethargic. You go in the room and you try to waken them and they are very sleepy. They just don't even want to open their eyes or acknowledge that you're there. They're confused or disoriented and they can't follow directions, and that will progress on then to the symptoms you see on the right side of the page, your cardiac dysrhythmias, meaning the heart rhythm is abnormal. They have electrolyte imbalances. They can actually go into a cardiac arrest, and then we have very serious consequences from that. Hypoxia, hypo is below, OX in the middle is oxygen, and IA is a condition of. So breaking that down, you have a prefix, a root word, and a suffix that help us to know that this is a low level of oxygen to the tissues. So this is at the tissue level. Early symptoms, patients will kind of be confused, and when you have hypoxia, working nights for many years, I can tell you that the one that says restless is where I want to tell you to look. You go in the room and they have their call light on, they're just kind of antsy-pantsy, and you don't do a good assessment. You think, oh, they just need a sleeping pill. turn on the lights, take the covers and pull them back. Do a full head to toe assessment. Get a set of vitals. Check their O2 sat, because when you have a patient that's hypoxic and that early symptom is restlessness, you're going to walk in the room the next time and you're going to have a patient in very severe problems. And so learn early on. Don't dismiss when a patient is just kind of restless or confused for you. When we look at the causes of this, there are a lot of reasons. A low hemoglobin, they're not carrying enough oxygen to where they need to go. They're not inspiring enough O2. They're taking shallow breaths. Maybe they're in high altitudes, or they have broken their ribs and they aren't taking good deep breaths. Maybe the tissues cannot extract oxygen from the blood, like cyanide poisoning would be one example. Or they have decreased diffusion, and we talked about that in part 1 of oxygenation. Maybe they have a lot of mucus in their lungs because of pneumonia. Patients in shock will experience hypoxia, and that shock is a result of lower tissue perfusion or hypovolemia. There's not enough blood flow or blood volume to push the oxygen to the tissues where it needs to be. And then impaired ventilation. Any patient that's in a motor vehicle accident or any type of trauma where they have chest trauma, we worry about their oxygen status and the lungs and the ability to breathe on their own. And we watch those patients. Oftentimes, if it seems like nothing's wrong, they will admit them overnight for observation, just to keep an eye on them and make sure things are as they should be. Your signs of hypoxia, initially the vitals go up, and that's the body trying to say, hey, something is wrong. So when you go in and check blood pressure and pulse and you think, wow, they were at 80 before and now they're at 95, what's going on? That's when you, again, do a more thorough assessment and call in maybe a nurse that has more experience to help you if you think you're missing something. And later on, you'll see that the blood pressure and pulse decrease, and that's because the body has compensated, but it's running out of energy and it just can't keep up. Again, the dysrhythmia or the abnormal heart rate that we see on a telemetry monitor, decreased LOC is level of consciousness. Again, you walk in the room, they just don't respond to you. They appear to be sleeping, but when you go to awaken them or shake them or do something, they're just real groggy and lethargic for you. When we talk about use of accessory muscles, that is where you will see the ribs. When they take a breath in, it will pull in, or they will be using more of the muscles in the trunk of the body to help with assisting with respiration. Stridor is a very high-pitched kind of crowing sound that you will notice when you listen to lungs or stridor. Oftentimes you can hear just by being present in the room with the patient. It's a very high-pitched, and it means narrowing. It's like the airways going through a very small tunnel. And then that central cyanosis, put a star by that. There's several questions on the test related to central cyanosis. That is when you look at the patient and their gums, their lips are blue. When you have central cyanosis, it's a very serious condition because the core of the body, which gets priority for oxygenation, obviously cyanosis is lack of oxygen. That core of the body is not getting oxygenated as it should. When we look at hypoxia, if you're one of those that learns very well, these are, just little mnemonics that we have that might help you remember that. When we compare central cyanosis with peripheral cyanosis, good to think about how they're the same and how they're different, and that would be a good activity for a note card. As we look at hypoxia then, what causes that is usually something occluding it. Mucus secretions. Do they have a lot of thick mucus that's keeping the airway from being able to do what it needs to do? In that case, as a nurse, I would either give a breathing treatment, I would suction them, I would do chest percussion, I would have them cough and deep breathe. I'm going to do something, and if I don't know what to do, I'm calling in respiratory therapy, or I'm calling in the head nurse to help me figure it out. Oftentimes, the obstructed tongue is back in the recovery room when a patient has been anesthetized for surgery and they're just starting to wake up. That tongue slips to the back of the throat, occluding, and we have an oral airway that we can put in that helps kind of hold that tongue in place. Foreign body aspiration is very concerning. That might be a child that has swallowed a McDonald's toy and it's stuck in the airway, causing them to not breathe. One of the worst experiences that I know of, luckily I was not working that night, a very small child was playing with a balloon, and the balloon burst, and just the fragments of the balloon, the child aspirated that, and it's wet and sticky, got down in the airway and totally occluded the airway off. And as the nurses tried to do CPR and tried to open the airway, that balloon was occluding, not allowing any of the air to go down into the airway, and that child died in the ER. It was very sad, but as we think of what is the foreign body that's down there, a lot of times it's food. Vomitus is one that we see. Somebody that's gone out and drank too much, the body wants to eliminate that vomit, or wants to eliminate that toxin of the alcohol, because the liver can't detoxify it fast enough, and that person will vomit. And it's always sad when somebody is found in the bathroom laying beside the toilet and they've aspirated their own vomit and died. But that's a very real complication that we do see with kind of a drug overdose or an alcohol overdose. COPD, chronic obstructive pulmonary, that's where those alveoli are not responding or not elastic like we wanted. And then occluding by water when you have a drowning victim is also a reason that we might see somebody with hypoxia. When we look then at some of the causes, again, many of them are surgical with your abdominal surgeries, or extreme obesity, the person that has so much weight that they can't take a good deep breath because they have to move so much weight and tissue around those lungs that they become very tired from just the effort of doing that. Many of your people that are extremely obese will also have sleep apnea, and they will have to wear a sleep monitor or a CPAP machine at night to help encourage or force the air into their airways so that they are getting enough oxygen as they sleep at night. And then as we look at abdominal binders, people that maybe have a bad lower back and they put something around their midsection to help kind of support that back, well, it doesn't allow you to take a good deep breath. I was in a wedding a few years ago. We wore strapless dresses. I was afraid dancing and all the activities that this dress was going to come down. And so I had my dress pretty tight that day, so I knew nothing was going to move. Well, I don't think I took a good deep breath all day, and that's very similar. When you think of Scarlett O'Hara and Gone with the Wind, they wore very tight corsets and dresses to make their waists look small, and many times they had to use the smelling salts because they were hypoxic. Other causes can be things like drugs that depress the central nervous system, any kind of brain trauma, because of the brain stem is where your respiratory drive comes from. Many of your patients in like diabetic comas, your diseases like multiple sclerosis, myasthenia gravis, affect the muscles that in turn affect the airway and the ability to breathe. And with multiple sclerosis, they become weaker. Myasthenia gravis, they become weaker as well. And then your patient that climbs Mount Everest and they're up in the altitudes oftentimes will have to descend sometimes because they are hypoxic. Their body is not used to that high altitude and the lack of oxygen in those high altitudes. And then the next and last condition we will look at is hypoxemia. EMIA is a condition of the blood, and so it's just low oxygen in the blood. And this precludes or comes before the hypoxia, because if you don't have oxygen in the blood, it will not get down to the tissue level. Symptoms of chronic hypoxia, and the key word I would underline here is chronic. Just being hypoxic for an hour or two, I will not have clubbing of the fingers. That is only people that have long-term. I've only seen it once in a young person. It was a young man that was in a house fire at a very young age. He had a lot of scarring and damage to his lungs, and by the age of 16 he had a very classic clubbing of the fingers because he had such chronic bad lungs from that house fire. Your patient with a lot of dysrhythmias, you will see they're very fatigued because they don't have oxygen and very short of breath. And the word I would scratch out and put in there instead of saying shortness of breath would be dyspnea. They are dyspneic as a result of that. And so just in summary, we know that it's at the cellular level when they're hypoxic. It's very life-threatening. Do not be afraid to administer oxygen. That is a treatment as nurses we are required to use. Thank you.